Shall I pop the agenda up for everybody to see again?
Good
Or
idea.
can I ask Maria too? Because I think you've got the most recent version.
Yeah, of course, bear with me.
Let me know if you want me to start or when you want me to start.
I think everybody's back in now, Katie. Should we kick off, Rukeya? Yeah. Over to you then, Katie.
Please.
Thank you. I'll get started. I know we're keen to keep to time. I'm just going to share my screen and share my presentation, The Power of Being Heard, a perinatal peer support model for perinatal mental health. So just bear with me while I share. I don't need sound, so luckily we've not got that pitfall to fall into. Okay, can you all see that on your screens, my sort of title page? So my presentation is called The Power of Feeling Heard, a peer support model for perinatal mental health support. So what is our service? What is the Perinatal Support Service? So we are a family action service. I'm employed by Family Action and so is all my team. And we are commissioned and funded by Better Start Bradford through the Lottery Community Fund. So we support women in the Better Start Bradford area of Bradford. We provide two elements of our service. So we have peer support volunteers who provide listening sessions to mums, and that's the focus of my presentation today. Mums feel heard by their volunteer. They can share and offload their worries and feelings, and they can do that in a non-judgmental environment where they feel safe to share and offload, and they know that their volunteer will be there specifically and purposefully to listen to them and to hear and to validate their thoughts and feelings. We also offer a group called My Baby and Me, which focuses on bonding and attachment and is done through Theraplay, which focuses on interactions with baby. And I use this strapline to sort of describe our service. We put mums in the centre. We put mums in the middle of everything that we're doing, as I'm sure everybody on this call today absolutely does. I've just popped a quote on the bottom of here because I love this quote from one of our service users, recently closed. I would actively promote the perinatal support service to others. I think it could really turn things around for individuals and for families. And for me, I think the key bit is that end bit, and for families in there. We've been talking a lot today about working in an integrated way with a whole family approach. If we can give support to mums in the perinatal period and support them with their mental health and how they're feeling, we can actually put support in with the rest of the family as well. I want to draw your attention. I've just put where the data's from at the top of this slide, so I don't need to particularly talk about that. Some perinatal mental health statistics from 2021. There's lots of little small bits of the pie chart here that describing difficulties with perinatal mental health, and I think Abbie drew attention to some of those at the beginning of this event, which I think was really powerful and really kind of brought us all down to earth about why we're here and why we're doing what we're doing. But what I want to focus on in my presentation today is this large blue section at the bottom of the pie chart, which is 72% of mentally well mums who were mentally well through their perinatal period, including when they were pregnant and up until their baby turning 1. They were generally mentally well. They still experienced negative thoughts, and those could be negative thoughts about their pregnancy, about themselves, about them as a parent, about their baby, about their ability to parent, about their family in a wider way. So it's really important for us to think about normalising this experience that most mums during the perinatal period will experience some negative thoughts. They will think that they're failing, they will struggle, they will feel like they're not coping as well as other people. None of us mums in our perinatal periods are living up to this social media ideal of this perfect parent, and it's really important for us to talk to mums to explain that it is completely normal and that there is support and they can access that support. Our target mums are mild to moderate mental illness and mental health issues, which would include anyone experiencing any low mood. So very much focused on those 72% of generally mentally well mums just having a bit of a difficult time. And the next section on the pie chart, the purple one here, I don't know if you can see my cursor, the mild to moderate mental health problems. So why do we provide a peer support service? Why do we think that peer support is effective support? So on this slide, I've just shown that in 2020, the Peer Support Network Supportive pulled together a white paper that synthesised 120 research studies, and that cited really strong evidence that peer support was as effective as group CBT. And the magnitude of improvement seen from peer support was similar to psychotherapy or accessing and taking antidepressant medications. What we want to do with our peer support is get mums from what you can see the picture on the slide here. So this is a really classic kind of typical encounter. So we've got a pregnant mum and a mum with a young baby, and one of them says to the other, "How are you?" And the other one says, "I'm fine." And off they go. But that's not really the truth, is it? That's not really the true picture. Neither of these mums are likely to be completely fine on this day. And perhaps one of the mums was asking the other one how they were because they were wanting an opportunity to say that really they weren't doing completely fine at all. But this is a classic thing, and it goes back to that stigma and that feelings of failure, feelings of not doing as well as everybody else. Mums do not share their thoughts and feelings. They feel like they should be coping, and they feel like if they do share their thoughts and feelings, they will be judged. And the end of that spectrum of responses is that they will end up having their children removed, as I mentioned before, and I'm going to come back to that later in my presentation. So we want to get with peer support from this, "How are you? I'm fine," to this, where both mums in the situation, rather than feeling the need to share with each other, can share with their peer support volunteer all these thoughts and feelings about getting it together, feeling like they're feeling bad about things, feeling like their brains don't work anymore, feeling like physical symptoms, feeling really sick, all of those thoughts and feelings that all mums have in this perinatal period, whether they're pregnant or they've got a young baby, being able to actually share and offload all those thoughts, feelings and worries. And what we find in the peer support, volunteer support that we do provide through our service is that this is very much what does happen with our mums. They feel that they can share and offload, and they experience the power of being heard, the power of really feeling that you are heard, that you're listened to, your thoughts and feelings are taken into account, and those thoughts and feelings are validated and normalised, and you are reassured. So some outcomes and impact from our service, and this is to sort of back up that evidence from the supportive study. Our outcomes for peer support throughout the year 2021 to 2022 an average reduction of 2.24 points on the PHQ outcome tool, which focuses on feelings of depression and low mood, and an average reduction of 3.13 on the GAD outcome tool, the General Anxiety Disorder tool. So some really powerful outcomes on average across all mums who got peer support from our service. I'm going to move on now to some qualitative, some quotes about peer support, and I think these are a lot more powerful than those just basic numbers. So I've put some quotes on here about the impact of peer support, and I've tried to capture some different outcomes. So the first one on here, mum feeling more confident, motivated and productive, and before this hadn't realised the power of talking and being listened to. A bit more of a really basic answer, but it really just as powerful as the first one. Offloading and venting to my volunteer helps me feel better and less stressed. That's what we're looking for every mum, feeling better and less stressed out. Great, fantastic. Having support from my peer support volunteer has been really helpful to me, managing my emotions and sharing the challenges of parenting. We were talking in Rachel's presentation, weren't we, about the challenges of parenting, and that parenting is so hard for everybody. And then if you don't have support, if you're financially worried, if there's all those other things impacting, those challenges are even more real than they are for those of us that have got all our ducks in a row. So helping to manage her emotions and sharing the challenges of parenting. The next one on the screen, being able to talk really helps me. I'm really grateful I had the opportunity to talk and offload. I always felt much better, being able to let it all out and as though a weight had been lifted. And then the one at the bottom, I actually used in my annual report for Better Start this year. Without the perinatal service, I'm not sure how I would have coped. I had no idea how to manage my stress levels, and I knew it was important for me to be less stressed for the baby while I was pregnant and after baby came. I really liked having a listener who called me each week, and I liked having someone to check things out with. So that was just to give you all some ideas about the kind of outcomes that our mums get from receiving their listening support from their peer support volunteer. I'm now going to go on to a client story, which one of our clients very kindly gave us permission to share her story to really demonstrate the outcomes that can be had from our peer support. So this is our client story. This client, as I mentioned earlier in the event, she came to us, she actually met one of our community engagement workers in a health visiting clinic, Lynn Walker, one of our community engagement workers who some of you on this call will know. She's been in Better Start and working for Family Action for a number of years and is very involved in the community. Lynn's very engaging and friendly and chatty, and she's not an NHS professional, but when she spoke to mum and asked her how she was doing with her well-being, mum's immediate response was to be extremely cautious and came across that way to Lynn, who really picked up on that. And that was related to, she later told her coordinator in the assessment, that she felt if she admitted that she was really struggling at that time with her low mood and anxiety and feelings of struggling with her new baby, that genuinely social workers would turn up and take away her 3 children. She was really, really anxious and worried, and she came across to Lynn as very cautious and very cagey. Lynn gave her one of our taster packs, which is a little bag full of information about our service and some little free gifts for self-care for mum. And I think there's a little pack of bubbles in there for playing bubbles with your baby as well. So Lynn gave mum this taster pack and said, just take this away, it's a free gift for you. I'm here every week. You can always pop in and see me if you think that you would like some support. So this mum went away with something to think about, and actually 2 weeks later, having looked through all the information in the pack, she felt actually maybe this was something that she could trust and she could access for some support. So she came back and met Lynn in clinic, and Lynn took a referral. At that time, it was actually captured on the referral, baby was 3.5 months old and was mum's 3rd child. Mum had a really difficult relationship with her husband. There was a lack of trust there, and that had been made worse each time she was pregnant. So this was her third pregnancy and had her third baby. She also had a real distrust of professionals, which I think was reflected in her feelings when Lynn asked her that question. And that was because she'd been told really negative things throughout her 3 pregnancies. And she felt that through her pregnancies and at the time of all 3 of her births, she wasn't listened to. And she really had this really big distrust of professionals and negative feelings. And together with her relationship with her husband and the difficulties and strain there, this had led to really low mood throughout her pregnancy. And she'd also had, in this 3rd pregnancy, developed a rash all over her body, which was very itchy and kind of felt hot and hurt at times, which had also contributed to her feelings of low mood. She felt very unsupported by her husband. He wasn't doing any of the childcare or helping out with the older children. She'd got this very young baby. She also felt judged by her own family. She found that when she talked to them about anything to do with baby, they just immediately told her what she should be doing, how she should be feeding, what she should be doing with baby, what she should be doing in terms of handing baby over so she could have some time to herself and things like this, instead of just listening to her. And that had led to a situation where at the time of the referral, when she was going out and about in the community, she felt that people were looking at her and judging her as a mum. And this had come through what she said in assessment to her coordinator. However, through her assessment, the coordinator felt that actually she was a lot stronger underneath than she was presenting at the time. Although she was very vulnerable and there was a lot going on, a lot impacting on her mood and her mental health, she was really strong. She really wanted to make changes and improve things. And she found talking about her thoughts and feelings through the assessment process. Our assessment is very conversational and it's all questions and answers to mum about her well-being and how she's feeling, what's going well, what's not going so well. Speaking and talking about things, she actually found that really therapeutic and described that as quite cathartic. She was already getting that feeling of offloading. So at the end of the assessment, the coordinator paired her with a volunteer, and mum said straight away that she wanted to have a volunteer and she wanted to have weekly support, and she wanted that to be face-to-face home visits in her own home. She really wanted to continue to get this support from being listened to and being able to share her thoughts and feelings, because she'd found that really useful already. The coordinator really carefully paired this mum with a peer support volunteer. This peer support volunteer was a mum herself, had 2 children, similar ages to this mum's older children, and also had been through a difficult relationship with some lack of trust and lack of support previously herself. So she'd got some things in common already with this mum and was going to be able to bring those lived experiences into the support. Mum really wanted to carry on, as I said before, sharing her thoughts and feelings. The coordinator felt that mum really was willing to get ready and make some changes, improve things and move things forward. And the fact that she was willing to access this support and get going with the volunteer and the peer support, the coordinator felt that this particular volunteer had really active, positive listening skills, which would really effectively support this mum. And the coordinator thought at the time of assessment, which did come true, that it would probably be quite a short-term intervention because this mum was ready to get on with the rest of her life. The outcomes for this situation were really fantastic. It was a really short-term intervention. The volunteer and the mum had 6, which we normally contract for, 6 weekly face-to-face support sessions. And then at the review, it reduced to fortnightly sessions. They only had 2 fortnightly sessions, and mum contacted the coordinator and said, "This has been absolutely brilliant, but I don't need it anymore. I know my next steps and I can go forward from this platform of support." So just captured some outcomes here on this slide. The PHQ score reduced from 6 down to 3, and the GAD score reduced from 7 all the way down to 1. So anxiety really, really reduced through this very short-term intervention of peer support. And I've just captured a couple of quotes here which I think really sort of sum up this mum's experience, that she found the support invaluable. She felt so much more confident. She wasn't worrying anymore about what people thought of her. She knew that she was a good mum, she was doing her best, and the service had helped her reflect on her life and take control of it. I just think that last quote there is just so impactful to me, that that's what we had helped her to do by providing that peer support. I'm going to stop there very shortly just to ask if there's any thoughts and questions. I have got a bit more presentation about the other sections of our service, but that was the end of the sort of power of feeling heard section. I just wanted to ask if there were any thoughts or questions, so I will just, if I can, stop sharing. She says confidently, stop sharing. There we go.
Thank you, Katie. I don't know if you're aware, but we had some technical issues going on whilst you were presenting. Everybody got kicked out completely.
Oh, I'm so
and then
sorry. I didn't
No,
know that
don't-
at all because I could only see my screen. I'm so sorry.
I'm glad that you were blissfully unaware. It wasn't too long that everybody was kicked out for. I think people managed to come back in again quite promptly. So yeah, hopefully everybody can see and hear us now. Over to
Oh, I'm
you.
so sorry. I would have
Questions?
stopped. I didn't realise at all. I'm so sorry.
I think it's probably better that you were unaware, because you just carried on smoothly and everybody just came back in as soon as they could. So I'll pass to Amanda because Amanda's got her hand up.
Katie, thank you for that. I suppose my question, well, it's less a question and more a reflection and a bit of a question, because I don't think there's an easy answer. But one of the things that I heard you say was that when you were talking about the case studies is that they don't feel listened to. And we know that that is a theme now. We hear it, we've heard it from all the inspections of maternity units that have come up. We've heard it, you can see it on social media at times. It's not unique, I don't think, to maternity at all, but it is a theme. And I'm interested just in terms of what you think we need to do to respond to some of that in a meaningful way, because we're not with any intent, but we're clearly not getting this right. And I just wondered what your thoughts were, because it feels like we need to be very radical, and it feels like it's going to be a real culture shift.
Yeah, I think it's a really good point. It does. Oh, I seem to be echoing. Is that for other people or just me?
Katie, I'll put myself on mute because it might be just.
Okay, Amanda, thank you. Has that solved it? Okay, great. Yeah, I think it's a really good question, and if I'm brutally honest with the people who are on this call, I think for maternity services and across health, I totally agree with you, it's not just maternity, but I think across maternity service it is the key question. We constantly get mums coming into our service who say they weren't listened to, nobody asked them what they wanted. And this particular mum, she'd had 3 pregnancies and 3 births in Bradford. I'm not saying she was in better start for all 3 of those, but she had lived in Bradford through 3 pregnancies and 3 births. And we can't minimise feedback that comes from the horse's mouth, not to be rude to this mum, but we can't. That's the feedback that she gave us. She said she wasn't listened to throughout her 3 pregnancies and throughout her 3 birth experiences. And I just want to, on a little bit of a personal note here, and this isn't to hold other places up as doing better, and certainly not better than Bradford in any way, shape or form. My sister lives in Berlin in Germany, and she's very recently had a baby. She wanted to have a baby in a midwifery unit round the corner from where she lived, and she had built up a really good relationship with the midwives in that midwifery unit. In the end, she couldn't have that, and she ended up having an emergency C in hospital in Berlin in Germany, and that's what happened. But she said that the thing that made it not traumatic for her, that she didn't get anywhere near the birth experience that she wanted, was that when she arrived at hospital, they said straight away to her, we know this is not what you wanted, we have your birth plan, we know this isn't what you wanted to happen, how can we make it as good as possible for you? And the fact that she was asked that and listened to, and her partner was listened to, made that, even though it was completely the opposite of the birth experience that she wanted, she said, I was fine with it. What we hear time and time again in our service, I'm sure this is the case across lots of people, is women do not get that experience. And when you don't get that experience and you don't get listened to, it can turn something that actually wasn't that bad into feeling more traumatic than it needs to. I'm not trying to browbeat anybody, because I'm in the centre of this, the same as all of you are at all whatsoever. That's my opinion.
Yeah, no, that's really helpful, Katie, because I think unless we have these very authentic conversations that say, look, our women, this is what some, not all, because, you know, there's many women that have a really positive experience. And I think what we risk sometimes is that binary approach. Either it's all terrible or it's all amazing. Well, it's a mix of all of those things, isn't it? And there's real grey amongst that, where we get some things wrong, but we get some things very right for individuals. But if there's one thing that we could pick on for me, it's how do we listen to our women? Because actually, that's not about necessarily being really busy. It's not about because in your interactions, it's how we interact, isn't it? And how we give them space to say, this is, and it's so simple. That example that you gave us just then is so incredibly simple in terms of, we know this isn't what you wanted, but actually this is what we've got to do now, and how can we make this the best it possibly can for you and your partner? It's just incredibly simple, but incredibly difficult. So no, that's really helpful. Thank you for that, Katie. It's generated a bit of interest, so there's other hands up, Katie.
Could I just, I'm jumping in. I did have my hand up, but I think Rukeya had her hand up before me. So, but it was just because it just really ties on to the end of that, really, that if we want our staff to be able to do that for women, then we need to be able to do it for our staff. It's all about role modelling, and it's all about relationship. So if we foster that internally within how leaders talk to their staff, then their staff will talk to their clients in that way. If we're talking about a workforce that feel browbeaten and feel overwhelmed and stuck, then they won't have the, their hands are off the circle. They aren't able to meet the needs of those clients because their hands are not being held. It's, it all comes back to the same thing, doesn't it? It's all about relationships. If our staff feel well supported, safe at work, listened to, spoken to well, valued, then that's how they'll behave with clients. And I think that's it's so simple, but it's so hard.
It's the compassionate leadership piece, Rachel, I think, isn't it, that we talk about, but actually we have to walk the talk and really play that out, I think.
And I think one of the difficulties, and this isn't just in maternity, this is worldwide, is that often people who end up in leadership positions are not the most nurturing and compassionate people, because it takes, I'm not saying none of them, but what I'm saying is, there's a personality type that drives people into leadership, and it often doesn't go hand in hand with being compassionate and nurturing. Those things can sometimes sit quite separately, and unless it's a cultural behaviour that this is how we behave, then things can get really skewed really easily, and then you just get a damaged, traumatized workforce. So yeah, that's just my little sorry.
Thank you, Rachel. So I wanted to come in on your question there, Amanda. That's a mystifying, baffling question, but really it isn't. In 2014, I was practice development manager and clinical midwife. Rachel and Abbie will remember the days, 2014. And that was the question I was posed. Women are feeling not listened to. And that was on the back of the Francis report. So we got shuttled off to London, where all the chief execs were all coming up to talk about the harrowing things that were going on. So we went on and sort of listened about the 6 C's. For me, it was a 7th C, which was about confidence, you know, that staffing and the support that you mentioned, Rachel. And I started writing a piece of work around that. What is it that makes someone feel confident? And by someone I'm referring to, it could be a very junior band 5 that demonstrates all the components of care, compassion, relationship building, the core foundations of the delivery model that, you know, it sort of equates to good, sound care. It's so simple and basic. When I returned back after listening to where things went wrong in the Francis report, people not being listened, communication being so poor, people not feeling empowered enough to be able to say, this behaviour, that behaviour, the way I was spoken to wasn't right, therefore I couldn't take this action. We came back, and one of the things that we developed at Bradford was the Care, Compassion and Communications workshop. We looked at all the feedback that women were giving, the complaints, to try and get to the bottom of it. And the key thing that kept jumping, and it probably still does, and I heard it in the conversations at the CMO meeting on Tuesday, was that acknowledgement that you discussed, Katie, the acknowledging that this was the expectation. However, this isn't where we are, and we wanted to be there. We couldn't give you the birth that you desired, but this is how your care is going to be. So going back to me, I've got 4 children, and my last baby was a section. She was quite big, and it was at Airedale. Oh, wow, home. So all my children were born at Airedale. I couldn't rate the care more strongly because it was like being at home. I mean, I knew the staff, but that shouldn't matter. But it was that acknowledgement that, yes, you've had 3 normal deliveries and you delivered and you've had perfect, well, I think they were perfect, obviously, had good deliveries, and then you're disappointed because it was a large baby, she was breeching, and we weren't going to venture out and do silly things as to be brave. But it was that wraparound from the consultant to the senior lead midwife down to the HCA said, we know that that's what you wanted and it's not going to happen, just like what you said, Katie, but we will do everything we can. It was just amazing. That section was just as good as the 3 normal births. So my point, I suppose, in a long-winded way, is the acknowledgement of the expectation a woman, a family has. But then what do we do when we can't deliver that? For whatever reason, it's that acknowledgement by the team that we will do everything we can to make it the best that it can be. That's what women want, regardless of language barriers, regardless of what their previous experiences were. What do we do this time round to make it the best that it can be? And if we don't acknowledge it, then we've not really truly listened. You know, it's not active listening. And very similarly, and I know I keep coming back to vaccines, listen to why I don't want this vaccine that's going to save my life and keep me safe, because that's the best known protection. I'm fearful of X, Y, and Z. Acknowledge that so that can be ticked off in my head and in my heart. And I know that you're truly taking me seriously and you're respecting my wishes and fears, however silly it may seem that I'm going to have another head or I'll suddenly turn into a mushroom. It's that kind of thing that we were laughing at. But it's when people become invisible, don't they? If they don't get listened to in a waiting room, just like what Nada's probably dealing with. If there is delay and we can't do X, Y, and Z, we need to explain. We need to speak frankly as best we can to say, yes, we couldn't, or this is the reason. And people understand. They don't want to be an invisible stat. That's the, you know, my experience. Thank you. Back to you, Katie, I think.
Thank you, Rukeya. Thank you, Katie. I'm just going to have to swiftly move on now to the next speakers. We've got the Bradford Doulas. Aliya, are you on the call? Yay!
Hello.
The lovely Aliya's here. I'll just move straight on to you. I'll let you introduce yourself, Aliya.
Fabulous. Thank you, Abbie. Hi, everyone. Sad that we got logged off because I don't think all 422 people came back, did they? We're like left with about 9. But hi, everyone. My name is Aliya Fazil. I am the project manager for Bradford Doulas. I'm going to be doing a double act with my colleague, Shelley. Shelley, do you want to introduce yourself?
Hi, everybody. Nice to see you.
Fabulous. Right, I'm just going to share my screen. So I'm going to do a couple of slides and then hand over to Shelley, who's going to present some lovely case studies for you. So if you could just let me know if you can see those slides. Yes. Yeah, fabulous. Great stuff. Okay, so we are Bradford Doulas, and find my little cursor if I go to the next slide. So who are we? So we are Bradford Doulas. We sit within a charity called Action for Community Limited. Not many people know this, but we've been here for more than 10 years now, which is pretty amazing. We have been funded by various pots of funding, predominantly NHS Bradford City Clinical Commissioning Groups, now Actors One. Yay! Someone needs to share the Actors One logo with me. I'm all about branding. We're also funded by Better Start Bradford. This is our 6th year in delivering that contract. And more recently, as some of you will know, we've been expanded with the Reducing Inequalities in Community Fund. So we're a team of 11, soon to be 14. So we're forever growing, which is amazing. And we have 2 key strands to the service. One is recruiting and training volunteer doulas, and we recruit within Bradford and really kind of grow your own, if you like, and deliver a level 3 accredited course. And then the service itself. So through the volunteer doulas and our experienced team, we provide 6 weeks antenatal support during the labour and 6 weeks postpartum. And we're quite a robust model. As I've mentioned, we've been here for quite some time. You know, we have agreed KPIs. We're now on system 1, and soon we'll be going through an evaluation process with Better Start Bradford. So many of you will know what a doula is, but I love this slide and always like to share it. So Maddie McMahon brilliantly elaborates this in her book, Why Doulas Matter. Doulas have always been here. They kept the wolves from the door when we burst in caves. We have many names. We are that woman in the village who always knows when your time is close. We appear with food, water, love, and strong arms. We shepherd the children, call the midwife, and hold the mother as she and her baby work together towards birth. And I think that just really encompasses the whole ethos of our model, really offering that practical and emotional hand-holding support, but also having clear set boundaries of non-clinical advice, and working really closely with our maternity services to be able to offer that personalised care package that our women deserve. Next slide. So Bradford Doulas is an evidence-based peer support model. And this was particularly looking at peer support models within maternity services itself. And there were 4 key areas that were very prominent within that review. One, that maternity services felt that doulas were complementary, particularly when it came to sharing public health messages like smoking in pregnancy, infant feeding, vitamins, maternal mental health, safe sleeping, and other messages. They trust the model. 80 to 90% of all our referrals come from our community midwives and antenatal clinics, and because they are aware of the benefits of what the volunteer doulas can offer. It's relationship based. We are consistently in conversation within maternity services at various levels. Our teams have built great relationships with voluntary sector services or the Better Start projects. We often support the cases together, so we might visit families together in a kind of like a 3-way meeting, and this is really helps to kind of offer that joint support and to assist that communication. And we've just been hearing just before our presentation how important it is that women feel in control about their choices and feel in control about their autonomy. And in order to do that, it's really important that we bridge the gaps. So it's very much about building that rapport and trust between the family, the voluntary sector, the doulas, and the health services. And finally, the project is respected and recognised as a continuity of care model. We offer home visits, we offer on-call support, we accompany to appointments. And quite frankly, we have the luxury of time. You know, we questioned earlier, how can we build, how can we listen to people? And quite frankly, we need that time to build those relationships and get to know our families. So in light of today's theme, this kind of slide just demonstrates the type of referrals that are related to perinatal mental health. I want to firstly highlight that many women and families will experience one or more on this list without ever being diagnosed or recognising that they even needed professional help, particularly around PTSD from previous birth traumas. But it's also important that we don't label people. We touched on this earlier about destigmatizing. It's very much about recognizing the symptoms that people are presenting and really listening to what those needs are. I also wanted to highlight that many of our new Bradford families, particularly those new to the UK, are dealing with complex traumas, repetitive and prolonged traumas. Some of the cases that we've been working with have dealt with grief, separation, war and terrorism, sex trafficking, victims of rape, and sometimes the pregnancies are a result of that trauma. So, you know, there's a huge implication on how women may be responding to their pregnancy, why they might make certain choices for their health, and how they will be feeling about the labour itself. Many have PTSD and previous birth traumas for when they laboured in their home countries, and they're now faced with a new maternity system and really need that support to navigate what that looks like for them. So as a service, we cover a whole module of perinatal mental health with our new volunteers and our experienced volunteers. And more recently, we have developed as a trauma-informed service. So we've been looking at some of the work through Better Start Bradford ACE's work. And more recently, we've completed trauma-informed doula training, which kind of focuses on the implications of trauma, but preventing trauma from reoccurring during the actual birth process itself. Through our training model, 70% of our volunteer doulas are members of the community they serve, so they share the same background, the same language, and you know, evidence suggests that doulas who are within the same kind of community or understand some of those deprivation factors can really benefit women of colour and families with language and offer that cultural sensitivity. And finally, I suppose I just wanted to really add there that often we might even get referrals with extreme or serious mental illness, and it's really important that we recognise what that professional help needs to look like, because it's not always within the remit of volunteer support. So we have quite a robust triage process in place so we can help women access support at the right time. So some of this evidence comes from the Cochrane report 2017, if anyone is interested, but I'm just going to highlight some of those in bold, which is more specific, obviously, for today's session, but feel free to kind of read through those. But a lot of this comes through, like I said, the 2017 review, which looks at continuous support for women during childbirth. And we've also been part of a University of York qualitative study, which looked at mothers and doulas experiences. And some of the key things that kind of come out from that is having a doula at your birth can really support physically and emotionally, and women have experienced coping better. They've expressed better birthing experiences. Someone mentioned earlier that it's never, you know, it's never a positive experience or a negative experience. It's a huge wide spectrum, but women are a lot more in control about their choices. They're better prepared by having someone to support them through that process, and therefore experience, you know, a more better birth experience. Parents have improved self-efficacy and improved parent-infant relationship, and we've heard about the great stuff that Rachel presented earlier. There's better recovery period, in particular with emotional well-being, and we find that women who may have had some sort of medical interventions or not quite a smooth sailing labour, for example, and may have longer recovery periods, but having a doula through that process really supports with that emotional well-being and coping with that recovery period. And finally, doulas will help to really build that social infrastructure before they leave. We often say and hear, don't we, it takes a village, and we have to not assume that our families in Bradford are, you know, in kind of wider communities or have extended families. If anything, it's quite the opposite. And having somebody as a professional, but also a volunteer who can offer that time can really help support that process. So I'm going to hand it over to Shelley, who's going to share some amazing case studies, and I think it's really wonderful to hear real life stories. So over to you, Shelley.
Fab, thank you. Is the sound all right? Yeah, great. So thanks for that, and hopefully some of these case studies will draw out more from what Ali has already painted so well as a picture. Look at these beautiful photos. Look at that little baby. Oh, and the one of the mum leaning on the birth ball, that's an antenatal photo. So that's from one of the doula sessions, antenatally with this mum, doing some relaxation and birth positioning stuff. That's the kind of thing we might do on a visit. I'm going to read out the quotes on the slide so they're not distracting you, and then I can tell more of a story. So there's a quote there from Mum. If I talk about my doula, I'm not going to finish. She supported me like my sister. And then from Dad. You are one of the people who will remain in our memories forever. Your presence with us is the most beautiful and difficult times means a lot to us. So I'm going to give some context to all of that in light of today's theme. So this lovely family, both parents were originally from Yemen, so a war-stricken country, and they'd been living in Saudi Arabia. For one reason or another, they'd had to flee Saudi Arabia because they didn't want to return to Yemen, so they'd had to leave all of their family behind, and they'd come to the UK and they were seeking asylum. So they'd been in the UK for less than 3 months, and they'd been in Bradford for just over 3 months when the family came to us. This was the 3rd pregnancy for this family, but really tragically, both children had died at under 6 months old back in Saudi Arabia. And with a little bit more conversation, the parents didn't know why, but it was later found out through the care they received here in the UK that it was a genetic condition that had caused those deaths. They received really fantastic care in the UK, and they got care from Leeds, Manchester, London, like really fantastic care to identify that, and then to make sure that all the care that was needed was in place postnatally for this pregnancy and this baby. So they'd had their story, they'd had the previous losses, we knew that, and they'd come to Bradford. So here they were, and as a doula was matched and worked with both the mum and the dad, and this was really special for the family because their pregnancy journey back in Saudi Arabia had been negative, and it hadn't been a partnership because of how the care over there was presented that they could engage with. So to the point where we found out, it was disclosed in conversations with the doula, that the when mum went into labour, dad wasn't allowed in the room. No one was allowed in the room with the mum, even though he was outside and could hear her crying and really upset and screaming. There was that separation and trauma there, like in that moment for them both, but he wasn't allowed to be with her. We also found out that mum had been strapped to the bed against her will and wasn't allowed to move. So there's like some really harrowing situation that mum's been through, but also dad's been through around the birth. So understandably, they were really scared and anxious and worried about the birth and then what was going to happen with the baby afterwards. So doula was involved and had the support of the locality officer, which is the staff team member at Bradford Doulas, and got involved and did 6 weeks antenatal period and did things like in that photo, and worked through birth planning. So Aliya's talked a lot about giving control, building up trust, rapport, choice, and that it was all about our services. Katie said it's the woman at the centre, like absolutely, it's all about that, making sure that the power is always coming back to the mum and the family, and that reassuring that they have got control and they've got power in this situation, especially when they're in the slightly wider, well, the wider situation of being in the asylum system, which takes away and strips away as much power as possible. So wherever we work, in whatever situation, no matter how vulnerable a family, wherever possible, giving that power back so that that choice is theirs, and therefore builds up a trusting and meaningful relationship between the family and the doula. Let's get to the birth. After like extensive birth planning, which I will touch on a bit more, was not just the doula being in the room with the mum and the dad and talking through lots of different choices. The doula would sort of take little bits, take the information and then leave it with them and give that time and space for them to have a look and then them to have a think. So again, like giving the power back for that discussion, and then the next time we'll be like, how was that? Have you got any questions? What do you think? And it worked really, really well. Sometimes, like, it was a fantastic family to work with in that sense that there was a couple and the English was good enough to do that when they would, and we'd do a bit of interpreter work and they'd do a bit of Google Translate as well. So it's a whole mishmash of things, but it worked really well and really made sure that in amongst all the anxiety, worry, the mum had said she'd been severely depressed prior, like following the previous 2 losses. There was a new way of being pregnant, a new way of preparing for birth that was their way, and that worked really well. So the mum went into labour, and there was like over the period of a week or so, it was like, oh, think we're going into labour. So the doula was like on call, and then things would happen and things would ebb and flow and not quite come to much, but the doula was there. So it was clear to the family that the doula was there, and the family told the doula very clearly, like, you're the only person that knows right now that she might be in labour, because we don't want to worry our family, because we don't want them to worry, and it's just an added worry. So you're literally the only other person in the world right now that knows that she's in labour. And I think that's, imagine if they didn't have that, like the burden, at least the burden's shared a little bit, I suppose. So anyway, when labour really started in its full glory, the doula was in the hospital with the mum and the husband, and met at the maternity assessment unit, and was really able to be there for both of them. So they were both really anxious. Be there, hold mum's hand, encourage them to do a bit of breathing, and just sort of bring that sort of jittery energy just down a little bit, which you could see, like when the doula talks about it, you could really see that impact and the feedback from the parents as well. And then when the family were moved through to labour ward into one of the rooms, the doula made some adjustments to the room, put fairy lights up, put the music on that the mum liked that had been played in previous sessions. Again, all mum's choices, and did lots of encouragement and reassurance and gave moral support to mum and to dad, because this was his first experience of birth. He really wanted to be there. He was like so worried inside. Whenever mum went out to go to the toilet, because there wasn't a toilet in that room, dad would be like turning to the doula and going, oh, and the doula's like, you're doing great, you can do this, you've got this. So very much, you know, in Rachel's presentation, the circle of security, those hands there, like the doula was really there for both parents and the baby at that time, and they were totally doing that. They were doing what they needed to do, and they just knew that they had someone there. And the birth outcomes were amazing. Spontaneous labour, no birth, no pain relief, healthy baby boy was born, and breastfeeding, and which was fantastic, and it was a positive experience. And then, so baby was born, there was contact with family, and the doula just sort of sits back at that point. Then there's the worry, like, okay, how's this baby? What's going to happen? Is this baby healthy? And so then that energy, that like jittery energy sort of starts coming into the room again. But the doula's there again to help calm that down. And then because there's language barriers and uncertainty, and that anxiety comes back, the doula at that point was really able to help clarify what the plan was, and work with the healthcare professionals in the room and outside the room to clarify what could be expected over the next few days. And again, that was really really important for that family, and to maintain and ride that amazing sense of well-being that had been built up through the labour. And so the doula was there, like, not just for the birth, but afterwards as well, which again can be talking about potential like traumatic birth experience. It's sometimes like afterwards as well that where those things can happen. So, you know, when the doula doesn't rush off and say, bye, have your tea and toast, you know, the doula sticks around. So in the like 3 days after the baby was born, the family received amazing news that this baby was okay, and that this baby didn't have the genetic condition that the previous children had. And it was the doula project that they rang first, and the whole team rejoiced. And then they told the rest of the families. And I think that speaks volumes, and community has been mentioned a lot on today's call, and relationship. And I think that, you know, that's shown in that example. So yeah, what else can I talk about? Because of the story, the experience of this family, this family were also working with Little Minds Matter, which is great. And we worked collaboratively with them. So the family were working with them, and also the doula and the staff member used Little Minds Matter as a sounding board, which was fantastic. So there was talk about like looking after staff, and the staff in a workforce being mentally well and supported and having those hands. So, you know, we use whatever resources we can, both like internally to our project and externally. We use that because we know that makes the world of difference to the support and care that the families receive. And yeah, I think for this family, having the right support in place at the right time really changed the narrative for them around their experiences of pregnancy and birth, and really felt that sense of choice and control and love, and also having someone, Aliya mentioned, you know, people being new to the country needing someone to help negotiate the new systems. This family got that from many sources, not just us, which was great. And in periods of overwhelm or mental distress, not understanding something that you feel like you should understand is just like the worst, especially when, you know, you feel like maybe your baby's life's at risk. So yeah, that's really good. So yeah, that's that case study. Let's move on to the second one.
Can I just chip in? Sorry,
Yes.
Shelley. Let's start Bradford are due to present at 3 p.m. Now we have more time on the agenda now because I don't think Nada's going to be joining us. So I don't know if Catherine and Sarah just need to present on time, or if you're able to hang around a little bit longer so that Shelley can finish.
Sorry.
Absolutely fine by me, if it's fine by Catherine.
Yeah, of course, no problem. Thank you.
Great, carry on, Shelley. Everybody's loving this presentation. Thank you.
Great. So again, so that you're not distracted by the slides and making the most of the wonderful quotes on the screen, let's start with the pink. Feedback from the mum. My doula gave me lots of strength at a really difficult time. In my darkest hours, my support was always my husband. After he went, I lost all hope. Then the doula came. Everything my doula did for me gave me hope. I know I'll face problems and I still have days I wake up and cry, but there will be solutions. So Aliya mentioned earlier about rebuilding social networks and not leaving people by themselves when we come to finish our work. And there you go, there's the evidence in that quote. So really tragically, this mum, her husband died unexpectedly in a car crash when he was abroad visiting family, when mum was 37 weeks pregnant. So yeah, when she said after he went, I lost all hope, that's why. So there we go. And then the blue quote from mum, I really miss you and my doula. I feel your absence. I know my time was limited. I never felt like I was speaking to a stranger. I really opened up. So like Aliya said, we've got the privilege of time, makes a world of difference to be able to be listened to and heard. And then the doula in the green, I learned about being mindful, but also acknowledging a person's trauma. I encourage people to feel how they are feeling. There's no right or wrong, and that's okay. And I think that that was her approach, and then mum's feedback speaks for itself, doesn't it? So yeah, mum, this was a really late referral, came to us when mum was 37 weeks after mum had presented to the maternity assessment unit, very distraught because she just found out that her husband had died, and then started working with the parent education midwife, who then referred to us. So a doula was matched at 38 weeks. Gestation, normally we match at 34. So that's a significant amount of time lost. However, those quotes show how quickly a trusting relationship was built. The model works, folks, the model works. So antenatally, we're doulas. We're there to support pregnancy and birth preparation and postnatal. That's what we're there for. That's what the doula focused on. We're not going to try and be therapists because we're not therapists. We're volunteer doulas. So the doula was there and wanted to work with mum to get together a birth plan so that when this baby was born, inevitably quite soon, there was something for her to work with. Within that conversation, inevitably mum was emotionally upset and distressed, and the doula held that beautifully, but kept her role clear and bringing that back to the birth plan, because we knew that that's our strength and that's going to support mum in the next stage of this pregnancy and birth. And within that, doulas are great observers. The doula noticed that how the mum was talking to her children, she was just not talking about the fact that their dad had died, and that was a really key observation to then be fed back to other professionals to make sure that the right support could be put in place for that family. And I'll go on to that in a bit later. As it turns out, mum went into labour and it was really quick, and the mum's sister got back in time to be there for her, which was great. The doula wasn't at the birth, but the conversations that had happened before with the doula were conversations that the mum felt she couldn't have with anybody else, because she just needed to hold it all together for everyone else, her children, her family, and couldn't focus on the birth. So the doula provided that space to do so. And then postnatally, the doula's support and observations meant that there was a successful referral made to SMABS and Little Minds Matter. And the doula's concerns about her children, about the children's handling of the grief, meant that this was impressed upon early help, and that the family were given individual and tailored grief counselling, and that an early help referral for a bereavement specialist health visitor was accepted, alongside a family aid worker being allocated, which was fantastic. And then this speaks volumes. The doula was invited to be part of the TAF meeting, the Team Around the Family meeting, and the bereavement midwife requested the doula's input into the family's assessment for input and suggestions, because it was so clear that that doula had such insightful observations, key observations that had come out of building that trusting relationship up to the point where the doula was able to give feedback that other people's, and paint a picture that other people couldn't yet see. But it all happened in good time because of the doula being there at the right time. Also in culturally specific support, it was Ramadan. The doula identified that the mum was going to really struggle through Ramadan with her family, and so we contacted a local mosque, and support was put in place in like donated food every week, and eligibility for zakat, and gifting children gifts. So that's all, you know. That's a big thing, not a little thing. I was going to say it's a little thing. It's not a little thing. It's a really big thing, and it's a really important thing. And it takes the right person in the right place at the right time to see those things sometimes. And yeah, for people to understand the communities that they're working with as well. Yeah, and there was more work done even around housing and schooling and stuff like that, again, because of that trusting relationship, and the doula being in the right place at the right time, and having that continuity of care on that time. And I think I can end there. Yeah, if there's anybody got any questions, have we got more slides, Aliya? Thank you.
Fabulous, thanks, Shelley. If anyone wants to take a screenshot of that, do it now before I stop sharing. But that was amazing. Yeah, any questions, please fire them at us.
Wow, what an amazing narrative, case studies, and I don't think anyone can argue with this. It was just the most powerful components that make that birth what it is. I was a home birth many years ago, and everything that you've talked about resonated in the birth story that my mum and my grand told me. That's what birth should be. You know, that nurturing, that wraparound, that enjoyment. I mean, obviously, aside from the labor and pain, if that kind of nurturing and that time that you talked about, away from the busyness of being in a clinical setting, is given by someone that understands holistic elements, understand care, compassion, and those very basic things, it can only empower this woman that's got to do that journey and come out of it with memories, powerful memories. I mean, goodness me, the Arab family with the sadness, and then suddenly it was just like this blossoming, that celebratory. I mean, you mentioned the word all the glory of labour. Well, that just absolutely captured it for me as a midwife. this is what it should be about, and this is the kind of environment we need to create. So you guys, massive applause from me. Absolutely fantastic. We need more of you, more and more and more. Absolutely.
Thanks, Rukeya. That's a lovely feedback. Thank you, and thank you for all your comments on the chat as well. But yes, yeah. So, Shelley made me laugh. She said, "Yeah, the model works, folks." I mean, no, it sure does. Did anyone have any other questions? I know we've got some. I know Catherine's waiting to present, so if yeah, Abbie. Kate, if you want to crack on. Oh, someone's got their hand up.
There's
Rachel.
a question from Rachel.
Snuck in there.
I just wanted to say that the family that you presented about first, I was the allocated worker at Little Minds, and they absolutely couldn't have spoken more highly about their experience with doulas and how vital that was in their whole experience. So I think just important that we recognise that it's life-changing stuff. It can be life-changing stuff that we get involved in, and yeah, just well done, guys. It was a really emotive case, that family, and such an amazing outcome, and I think a lot of their experience of that was because of the relationship they formed with the professionals involved. So just wanted to say that.
Thank you. Thanks, Rachel. Amazing family. They actually came back, didn't they, Shelley, and supported us with the visit with Dr. Bowler, the Director of Health Inequalities. Yeah, they were great. Dr. Bowler had a really lovely time just chatting with them, and yeah, it was lovely. It's great because often we don't get to see our families, and during COVID we haven't been able to do what we did pre-COVID, and that was bring our families together. So yeah, fingers crossed we'll be able to do that again this year. Lovely. Thank you everyone for listening.
Thank you so much, Aliya and Shelley. You guys, I love you so much. The model works, guys. The model works.
Model absolutely works. No doubt about that. It's bottling.
I just wanted to highlight a couple of the comments in the chat. That I think it was Natasha said, what amazing integral work the doula does, and I wish every woman had the choice to have one. Yeah, I mean, wouldn't it be incredible if every woman had access to a doula? And Amelia is considering a change of career. So yeah, spread the word.
Anytime, Amelia, anytime.
Thanks so
someone
much.
asked a quick question. What are the requirements for women to access the doula service? We are universal and we are citywide. But as you know, we are a volunteering service. So, often our referrals will come through and we will triage them based on capacity. So yeah, so there isn't a specific criteria for us. We are universal.
I just noticed that Amelia's just rejoined the chat, and I don't know if she heard your invitation to come and join her.
Yes, Amelia, wherever you are, I can't see you on the screen, but yes, come over to our side. Most people do.
I missed that, but it's probably a good thing because I've got enough on my plate. Thank you.
Fabulous. Thank you.
Thank you so much. Okay, so we're going to hand over now to Better Start Bradford. We've got Catherine and Sarah who are going to present for us. Thank you.
Hello, thank you very much. That's a tough act to follow, so I'll try to dampen my presentation nerves. I'm hopefully Catherine won't mind me saying I'm going to lead the presentation today because Catherine's not been very well recently, and you've got a residual COVID cough, I think, so you're not wanting to do a 20-minute presentation, but you will chip in the Q&A session afterwards. So any questions you've got that I can't answer, or bits that I flag up that Catherine's more knowledgeable about, write down your questions and then bring them to the end, and hopefully Catherine will be up to answering them. Okay, great. I've got some slides, so I'll give sharing those a go. Hopefully I've not used just tell me whether they go on presenter view or whether not. the presenter view for me. What can you all see?
Yeah, that's perfect.
Okay, good. It's a good start. Right, so I'm Dr. Sarah Macefield. I'm representing a wider team of people, a partnership from Born in Bradford, the University of York and the University of Huddersfield. I'm a perinatal mental health researcher, and I also do some research at the moment with Little Minds Matter, so it's a nice link up there as well. The work I'm going to talk to you about today was commissioned and funded by the West Yorkshire and Harrogate Health and Care Partnership. And the project title broadly is How We Reduce Inequalities in Perinatal Mental Health Care. So I'm going to whiz through this slide because I imagine that most of this won't be a surprise to you, or you're already all familiar with it. So mental health during the perinatal period affects up to 20% of new or expectant mothers and covers a wide range of conditions. So not just depression, of course. And the Nhs Long-Term Plan sets out how specialist perinatal mental health services will develop and expand to support moderate and complex to severe perinatal mental health difficulties. In West Yorkshire, we're trying to raise awareness of perinatal mental health difficulties and are keen to ensure our services are as inclusive as possible. Work is completed through the Perinatal Mental Health Partnership Board, so Jo Butterfield is the key contact for that. There are 3 specialist perinatal mental health services in the area, and there is a mother and baby unit that's based in Leeds. Historically, this has been centrally commissioned service, but it will move to be run through a provider collaborative next year. And I think if you don't know about that, Catherine might know more about that you can ask her about later. I've been involved with varying amounts of this work, so there are some bits where I'll be more knowledgeable than others, but overall the project was trying to achieve 3 things: to look at who experiences inequalities in perinatal mental health identification and treatment, why these inequalities might be happening, so the barriers and enablers. And within this, we were looking at the system, what's going on there, what the perspectives and experiences of healthcare professionals and voluntary sector personnel are in supporting women with perinatal mental health difficulties, and what the experiences of women from minoritized groups who've struggled with their perinatal mental health are specifically. And then the third aspect was, what do we need to change to reduce inequalities in this system? I'm going to go through these definitions really quickly because they're not going to be a surprise to you, of course, what the perinatal mental health period is. I won't cover that. That feels like that would be telling you things you know. The population, we obviously, or of course, we are aware that not everybody who gives birth identifies as a woman, but in this presentation, in this research, we are talking about women specifically. And then also we do understand that perinatal mental health affects partners, but again, we were just looking at the women's experiences of it and the support by women for their mental health during that period. Inequality, broadly, we're talking about unfair and avoidable differences in health caused by unequal conditions. Here we're focusing on disadvantages caused by socioeconomic, ethnicity, language ability or pregnancy related issues. And at all times when we're talking about prevalence, we are always talking about an estimate because it's very hard to get a really accurate prevalence from the data, and also of varying different sources, and we'll talk about that in a little bit. Yeah, but also that it's quite likely to vary by area for reasons that we'll go into a bit. Okay. So the perinatal mental health pathway that's defined by the NICE guidance and which we were looking at in this research includes identification of perinatal mental health difficulties via universal services, so midwives, health visitors, GPs, using the 2 depression identification questions, the Woolley questions, and then the GAD2, and also then further assessment to understand the actual clinical extent of perinatal mental health need, so via the patient health questionnaire and the Edinburgh postnatal depression survey and the GAD7, and then looking at referral and treatment for these needs onto specialist perinatal mental health services and, importantly, the voluntary charitable sector. So what did we find with our research? This evidence review that we're talking about has been published, so I don't know if Catherine's able to actually find a link to it and maybe put that in the chat, because that will give a lot more detail if you're interested than I can go into here. It's so as a summary, it's likely that the detection and management of perinatal mental health problems is inequitable. So we found that women who do not speak English experience a huge disparity, or are likely to experience a great disparity compared with women who do speak English in the identification of perinatal mental health needs, but also in access to the support that they may need. That there's also inequitable access and detection for women who are minority ethnic but who do speak English. Our research also showed an inequality for recent migrants and for women living in deprived areas. We found, but there was less research, and it was likely to be of a smaller magnitude, the disparities of age, socioeconomic status, and parity. But these are still highly likely to occur. So parity, the number of children that the woman has. What we identified were that there were significant gaps in the research for intersectionality, so how maybe socioeconomic status and ethnicity and any disability needs might interact in terms of the inequality that's experienced in identifying perinatal mental health needs and accessing support. And also in the explanations for the disparities, we didn't really find any research around why these inequalities are occurring. And there was an absence of the women's voices in the research as well, which we have tried to address. So why are these inequalities happening? This actually comes from a different piece of research that the wider team did, and I think Catherine was involved with. So if you're interested more in this word cloud and the research that informed it, Catherine may be able to speak to that later. But you'll be able to see that there are some key themes that we know are affecting the identification of need and the support that women are getting access to. So particularly, there's data issues, there's austerity, there's language barriers, there's the family as influential factors, migration status, the services that are available themselves and the design of those services, and then the kind of policy level as well, so the Nhs Long-Term Plan. This bit of research I was involved with, so I won't bore you too much with it, but I'll go into a bit of detail. So you won't be surprised to hear that the system is very complicated and there are inconsistencies in it. Our research looked at, sorry, I'm looking between two screens, but our research looked at the West Yorkshire area. You can see the map of the different trusts and CCGs in that area. So a huge amount of different providers who are supporting women with their perinatal mental health needs. We accessed the guidance provided to maternity and health visiting professionals in each of these different areas, and we compared them to see what information was being provided to these healthcare professionals. And what we found was that there are differences in the assessment tools that are being recommended. So whether it's the Edinburgh Postnatal Depression Scale or the PHQ-9, for example, and also that different threshold levels are being given across the different areas or the different trust CCGs. So it might be that one, for example, and picking a number a bit at random, that it might be that in one area, a threshold of 9 means a clinically significant need and a woman would be referred to a specialist service, whereas in another area, it might be a threshold of 6 or 7. And there were also different disparities in the role of clinical judgment. So in some areas, it would be that a clinician might be able to say, okay, well, your score is a 6, but actually I think that you have a need to go, so they could almost sort of work around, bypass the thresholds a little bit more based on their clinical judgment and reasoning. And then there were differences in the number and type of specialist roles available. So that's differences in whether there was a designated perinatal mental health clinician, so a specialist midwife, or whether there was a clinical lead in that area. And in some there weren't any named professionals. And then also in the specialist and VCS, voluntary charitable sector services available to the women that they had access to, particularly whether there were specific services for maybe minoritized groups such as migrant women or minority ethnic women. And these inconsistencies could disadvantage some vulnerable groups more than others, thus potentially widening inequalities across West Yorkshire. This is Catherine, the stuff that Catherine's super knowledgeable about. So I'll give a bit of a summary, but if you want more detail, that will have to come from Catherine, I'm afraid. But basically data recording around perinatal mental health is poor and it can be misleading. So we had difficulties getting data from all of the different areas in West Yorkshire. The data that we could access was not of the highest quality necessarily. That's not always because it's not being recorded in women's records, for example, whether they were assessed for perinatal mental health difficulties or whether or what their score was, but it's more that it wasn't being communicated. It isn't a requirement currently for, let's say, the score of a GAD 9 to be communicated, to be coded into the primary care record and then to be communicated to NHS Digital. So it's very hard for us to get access to that data as researchers to be able to see quite what's going on. So I think this is just for Bradford, this work that's on the screen here. Although the wider work that's not here, we did try to look at other areas, particularly Leeds, where they have really good data recording. But 7% of women in the Bradford area, I think, had perinatal mental health problems recorded. That was in their routine data, so that's in their medical records. But then when we look at the Born in Bradford Better Start cohort of women, we see that 32% of that cohort, that group of women, were having mild symptoms identified, and then 14% of them had clinically important symptoms. So obviously both those numbers, those percentages, are higher than the 7% in routine data. Now, we don't quite know what's going on, so we can see a disparity. We can see what you'll see from this kind of Venn diagram on the side, is that there were various areas of overlap between the different places that need was identified, and whether women who had a mild need recorded also had a need recorded maybe by a health visitor or by a midwife. So 3 in 5 of women with clinically important symptoms had no record of perinatal mental health in their health record. So that's a really worrying statistic. And those least likely to be identified were women with poor English language ability and who were recent migrants. White British women were most likely to be identified. So there was white British women were overrepresented in those identified as having poor perinatal mental health. Now, I'm going to go through some of the results that we got from our qualitative research. So we interviewed women, minority ethnic women who had self-identified as having perinatal mental health difficulties. And we also interviewed women, we also identified professionals from the voluntary charitable sector. I can't remember off the top of my head how many of these people we identified, but you know, I think it was somewhere around 20-ish. So I'm just going to pull out some of our key findings. Again, we're hoping to publish on this later this year sometime, but we haven't just yet. But it was a really big comprehensive piece of work. So some of the key themes are access to transport. So this woman said that the financial barriers were quite real. When you're an asylum seeker, you just get £5 a day per person, and that's for your food. That's all your toiletries, including everything, and they just forget about your travel. And if I had to go over to, she named the organisation, or for the mental health face-to-face appointment, I had to buy bus tickets, or I was getting late, maybe I had to get a taxi, and it just wasn't possible. And yeah, that was a barrier as well. So this woman, just with the resources she had available, she couldn't actually get to the support that she was being offered. And similarly with this next person, this was the barrier of access to childcare. That I'll let you read this one yourselves, but the service she was trying to access, they didn't provide a creche and they didn't encourage her to bring her child. So she couldn't go because there was nobody else to be able to have her child for her or children. And instead, the GP said, well, we'll just have to increase your medication rather than suggesting an alternative for her to access psychological therapy. Elsewhere, women found that the geographical location that they were in or where the service was a barrier. So they, for example, maybe if they lived in Bradford, there was a specialist service in Leeds, but they weren't able to get over there to access that service. Or it was also a major problem for women living more rurally in West Yorkshire. Some of the other key themes were around the relationships and knowledge of the service, both by the women, but also by practitioners as well. So the women felt that the practitioners weren't always aware of what other support they might need, that they maybe got referred to a perinatal mental health service, but actually they had childhood trauma, such as sexual abuse, that they maybe felt they needed to talk about as a wider, more holistic support for their perinatal mental health needs. and they didn't necessarily feel that there was the joined up services to be able to get the support that they really needed. And that's the first quote on the left. And the second one is talking about the importance of the kind of the clinical relationship, the rapport with the professional. So this was a positive outcome, that this woman felt that the practitioner really listened, that she understood, she felt that she just listened and she didn't judge, that she was really, really helpful, and even my anxiety and things, she got it, she understood. One of the slightly complex, I guess, findings that we found is that women from minority backgrounds didn't necessarily find that it was always helpful to have a practitioner who was from the same background as them. So, for example, the right-hand quote was a woman who found it really helpful to also have to be supported by somebody from a BAME background as well. It says here, so he's Black, his background, and I feel just like he understood the cultural kind of issues surrounding, you know, problems and anything that I'm facing. I feel like he's a bit more in touch. Whereas the left-hand quote, this woman felt like being supported by a fellow Asian person made her feel more uncomfortable, because that they might have some cultural assumptions, and that they would have friends and family in common. So this one says, I feel as though an Asian person would be like, oh, that's normal in Asian households, or yeah, this is how it is in every household. And I feel as though, like with the Asians, it's like, if there's relationship, that all of a sudden I find out she's related to so and so. At the bottom, it's a statement more broadly about stigma within services and issue of cultural humility. It's a really important quote, this one. We feel, you know, whenever you're an ethnic minority, a woman and a Muslim, you've got 3 strikes against you. You know, you feel like you have to prove yourself so much more than other people. Like perhaps it's the case, you know, the white medical staff are making assumptions about these women and they're not really taking their concerns seriously. So we did all this research, and we brought it all together in an expert panel, which had 19 participants from across West Yorkshire. They included representatives from midwifery, health visiting, specialist perinatal mental health services, other mental health services such as IAPT, VCS organisations, and also from local clinical commissioning groups. And so we took the findings from our research and then worked with this group to identify 10 key recommendations for what could really be done to change the inequalities in the system and in the pathway. These were, so the first one was perinatal mental health needs to be viewed as core business, not as a kind of add-on in maternity or health visiting, that perinatal mental health is everybody's business, and that it's absolutely critical and essential and at the heart of midwifery, of maternity services. Enhanced partnership working between statutory and VCS organisations. That was felt really strongly, that there needs to be just greater integration between the two. Third was a campaign to improve community understanding and awareness around perinatal mental health, but also around the identification of it, around seeking support for it. So visiting your GP or talking to your health visitor or your midwife, but also of awareness of what services and support is available. There needs to be more development of and commitment to routine staff skills training. And a lot that's also around the kind of the cultural humility, or around the identification and support for minoritized groups. That a skilled and equipped interpreter workforce needs to be available for perinatal mental health. That there needs to be additional support for vulnerable women. So that may also be, like I talked about, how there needs to be greater link up of services as well, and more awareness of the services and the sort of intersectionality of issues and vulnerabilities. There needs to be an equitable service offered across the areas. How we identified that there are these inconsistencies in the different areas in West Yorkshire, those need to be addressed. There needs to be consistency in the guidance, the services and referral pathways. There also needs to be changes in data capture and sharing. And there is the need for a review of information provision. So what's being provided to women, but also to the maternity and health visiting workforce. This is my penultimate slide. So some of this we've already covered, but a lot is happening in West Yorkshire. We don't want to be, we're not trying to be critical of what's going on. We know that there is lots going on, and we know that obviously everyone's operating in difficult circumstances and resource straitened circumstances, but we have identified some needs that need addressing. So we talked about the Perinatal Mental Health Board, and that there are specialist services, and there is a mother and baby unit. And this one is mostly just, this was a rallying cry. These are Josie Dickerson's slides. So she says that although we know that things need to have been done yesterday, we've missed yesterday. So the point is that the second best time to plant a tree is today. And hopefully we can try to make a difference and see things change now. So thank you very much. Don't know if I've stopped sharing. Hopefully, oh no, there we go. Right, any questions for me or Catherine? Yes, Rachel.
Just not a question really, but just a kind of that last or second to last slide that you were talking about perinatal mental health needing to be core business. It still astounds me that it's the highest cause. Suicide is the highest cause of death, or mental health related deaths is the highest cause of death in the perinatal period. But yet, we're still not funding it in a way that, you can walk into any maternity unit and there'll be a diabetic clinic and a blood pressure, preeclampsia. There's all these clinics for physical health needs that we know can be really significant for mortality and morbidity during pregnancy. But and it's not like this is a new thing. This is not just this year or last year that this has been a factor. It's this has been ongoing for a long time. And it just brought to mind really that we're still having to say that this is core business, even though that's been such a significant factor. And to share that really, that it's just still so frustrating that we're still having to say this. But yeah, thank you. It was really interesting.
Agreed. I'm not sure how we do say it any louder and make it change, but everyone here I'm sure is trying.
Can I just say, this is Helen Singleton. I'm one of the lead psychology people on the team at the community mental health place at Meridian. And I would certainly go out and see people, so I'm not sure if that's generally known, that if there are issues, of women not being able to get to Meridian for all sorts of reasons, childcare, etc., we will consider doing home visits. So they needn't miss out on psychological therapy if there is an issue. And we can usually squeeze some cash as well from somewhere if it's a case of the home visit's not what they would like. So just thought I'd make that point.
Thank you. Yes, so we're aware of some other services as well that say that they're much more flexible and that they encourage people to bring it, at least the baby with them. So, but yeah, I suppose maybe it's also about the mothers feeling empowered to ask if they have particular difficulties of access to.
It's a really important point that you raised, Helen, because it's something that I mentioned at the very beginning. We've got fantastic services and pathways and referrals in place, but does everybody, including healthcare professionals, is there awareness? And if not, how do we do that? Because the services exist and there are teams dedicated and passionate about it, but somehow along the way it just gets forgotten or missed. And what can we do to raise awareness of the options that are available? What could we do as a group that have met today to try and take something back? Is it something that we need to share with our colleagues? And not just share once, but repeatedly. And I know people get fed up of seeing flyers and posters, but what can we do differently? Is it a newsletter, or is there something audio? Is it the radio that says, these options are available should you need them? And that's one of the key things that makes me anxious, regardless of whether it's perinatal mental or neonatal stuff that, you know, is my background, that we don't probably raise enough awareness of things that are out there to support mothers, families. What could we do to try and signpost and make this wider knowledge is my question really to you all.
I think that was one of the kind of nicest things about the research that we did, finding that actually there's a huge amount of support for women out there, and there's so much going on, and like so many different organisations trying to do their absolute best. Sorry, excuse me, to support women and do their absolute best. And it's just about communicating that and making sure everybody's aware of it. That's half of the battle, isn't it? Like, the groundwork's there for people. It's just that next step of making sure that the people who are most vulnerable are aware of what's out there and what they're entitled to. Yeah. I didn't offer any any solutions, but it's just.
I think I know there's lots of, like we're saying, there is lots of people out there in terms of banging their drum, and everybody's trying to spread that word. I think, again, in terms of barriers, and again, this isn't aimed at anybody, but it's, you know, the maternity services are really busy. I think it's really difficult when, as Rachel just said, you know, they're not really acknowledged or paralleled with physical problems or differences. So if that isn't led from the top in terms of consultants and managers, so when it comes down to workforce on the ground level, so when it comes to things like, you know, the organisations, whatever background they're from, trying to gain access to those tight maternity circles, I know that's not quite the right word, but those sort of forums, I think it's really difficult for people to gain access, because at the moment they feel sad their own mental health. So in terms of going forward, again, you know, like Rachel says, there's a lot of support from Little Minds Matter in terms of restorative practice and supporting clinicians and people working with service users in terms of their own mental health, and then sort of allowing other organisations to become embedded and part of their normal practice. I think, as Sarah said, you know, she didn't use the word normalise. What was the word? Yeah, it needs to be core business. And I think unless these messages are filtered down as in sort of a role model sense, then they're never going to be acknowledged. I know for lots of the Better Start projects, it's really challenging for them to get seats in terms of being sort of involved in the midwifery arena because of their workload. But I think unless those messages are coming down from above to allow people in to support them with supporting service users, then I think that's our biggest challenge, really. So again, I think it's that diffusion of those messages and the importance that we need to put on our mental health.
You've really hit on, sorry to interrupt, you've hit on something really important that just I picked up on there, Rachel. When you said support, what did you use? Supporting or supporter services, something almost like a bulletin that goes in within the network, whether it's perinatal mental health teams, midwives, GPs, just saying, are you aware this is what's available? Almost like a reminder, because you're right, everybody's busy doing the doing in their own little bubble and area, and everything is important. But sometimes these key packages of care can be lost because we're so busy focused in our own specialism. But I just almost wonder whether, like a bulletin circular newsletter goes around saying, are you aware of X, Y, and Z from 1 to 2? Something that simple could work, couldn't it?
Yeah, I don't know. It's a real challenge. I'm sure Katie won't mind me using her as an example, because everywhere I go, I'm talking about the perinatal support service and the fantastic work that they do. But in terms of trying to bring that message to team meetings with midwives and bring that message to team meetings with health visitors, just to remember referrals, and equally we're there to support the clinicians supporting the service users. But like you said, they're tending to be very siloed at the minute, and I totally understand why that is. And in terms of accessing it, it'd be lovely to write a newsletter or something like that. But then it'd be lovely to think that it would be read. But again, it's maybe come from above in terms of managers saying this is what we need to do. I think to give it the weight and the kudos it needs, it might need to have some kind of protected time around it. You know, we're all seeing these massive issues that poor mental health can impact. You know, it's very far reaching.
Shall I chip in now?
That time, I think it's all workload and not supporting them in terms of, you know, allowing them to access that. And so again, I think it has to come from above and below and around, and we all need to be supported. But there does need to be some protective element, maybe, is my gut feeling.
I'm Jill Thornton. I'm head of programme at Better Start Bradford. And I just wanted to echo what Rukeya said, but also just to add to that, because I think it isn't just that women and families that are affected need to be told about the services, but I think everybody needs to understand that perinatal mental health is a problem that can be discussed. And I think that's one of the important things that Sarah's presentation highlighted, which is that lots of women don't talk about it, and actually don't talk about it to the people that they need to talk to us about. So there's two things that we can do: is make sure it's part of the conversation, so that everybody accepts that it's normal to experience poor perinatal mental health, and kind of, why not? This is a really hard world at the moment, and so it wouldn't be unusual to feel like that. But that also the services are there to support you, and so, you know, let's talk about it to your friends, and talk about it to your neighbours. And we do try to do that. I mean, we do stuff during Perinatal Mental Health Week every year, and try and get information out, and it's part of our sort of standard messaging. But I think it's even with that, that's comms stuff. It's not kind of changing attitudes stuff. And so I think there's more of that to do, is to just get people to see that, you know, perinatal mental health is part of that wider picture of mental health issues, which kind of is more and more part of the conversation now, and that people who are affected by it, and it is men as well as women, that it's okay for them to ask for help, and they should ask for help, because it's important for them and for their baby.
Thank you, Jill. Rachel, you've got your hand up, I can see.
Yeah, just to follow on from what Rachel was saying, really, about kind of the need for support for staff, really. I think when we've got an expectation that staff are going to be delivering these messages to women and families, and actually, you know, if they're struggling because, you know, the work pressures and kind of the stuff that they're experiencing at work, especially through COVID and all of that kind of thing, you know, how can they start to have those conversations with others when they're having to hold on to so much of their own stuff? But I was just wanting to say that, you know, we've made real progress, and what Rachel was saying about this coming from management, it needs to be a culture change in terms, and that has to be from leadership. It can't come from anywhere else. But I've recently been in meetings with Alison and Anne-Marie, and we're trying to establish some reflective discussion forums we've got 3 sort of pilot ones set up for some of the midwifery teams, and that the hope is, as part of the OMS, that we're going to try and get that out to every midwife, so that every midwife can be accessing some just reflective space, you know, nothing intensive, just something really informal where they can come together, talk about the challenges of working in these difficult spaces. And, you know, I think that's where it needs to start. You know, we need to make it normalised that we can talk about these things. It doesn't mean you're weak. It doesn't mean, you know, the thing that made me laugh more than anything at all is the trust. And, you know, whoever came up with this idea, sorry if you're on the call, but the idea of wobble rooms, you know, like if you're not feeling very well, you're having a wobble. I mean, just the derogatory terminology of that. And it's all well intended, but I think, you know, we're so bad at just being okay that sometimes you're not okay, and you don't have to go and shut yourself in a room and wobble in there and then come back when you're okay. Do you know, we can share this with each other, and we can, you know, we can be in it together. That's the way that we get it to women, is we model it ourselves, and we model it with our colleagues, and yeah. Sorry, I'll get off my soapbox, but yeah, just wanted to kind of share that.
Thanks for that, Rachel. Jane and Lisa have their hands up. I think Jane put hers up first, so let's go to you.
Hi, I was also thinking as well, like the criteria for which mums meet, you know, the perinatal mental health. The thing that I found, because I used to work on the mother and baby unit in Leeds before this job, I did 5 years on there, and mums that were like classed as having personality disorder or childhood trauma, their issues were never dealt with, and part of that is because there wasn't enough training. Just because you work in mental health doesn't mean to say that you don't need to do extra training. I mean, there's a lot around trauma focused sort of support now, but if staff don't get that training, then if they're delivering something to a mum, then it might not be the right sort of support. So I think it's all good and well having these services, but sometimes we need to look at the training that is needed to work with you know, individuals, because everybody's individual and everybody has different needs.
Yeah, I mean, certainly I think Little Minds Matter would attest to the fact that there's also just the difficulty of the healthcare professionals having the opportunity to take up the training, and that's been a real difficulty, which I suppose speaks to our finding of the real need to integrate with other services as well. So instead of, if there's not the capacity for the training, maybe there's the opportunity to help signpost and work collaboratively to fill the gaps that aren't filled in a service's skills and capacity itself. Thank you. Lisa.
Yeah, I was just thinking about when you were talking about raising awareness, and I just wondered if it's time, you know, for some national support with that, because, you know, obviously all the teams work really hard in Bradford, and, you know, there's a lot of work goes into that, but actually perhaps we need some support from government, you know, some actually, you know, public awareness information films, things like that, something from the Department of Health perhaps. You know, so it's shown that it's taken seriously. Let's get some adverts, you know, on TV, and, you know, to actually get that message out there. And I know, Rukeya, you said that you'd met with Chris Whitty, and I'm just wondering, he would be a good person to have on side, wouldn't he, to sort of get a public health message out there that's going to reach people, you know, in the break of Coronation Street. Yeah, and I was thinking, you know, why don't we aim high? What about the Duke and Duchess of Cambridge? You know, they're spokespeople, aren't they, for mental health? You know, why not? Well, we should be inviting them up to Bradford for a visit, shouldn't we? And, you know, how much publicity would that create, and, you know, excitement and interest, you know, and positivity if we could get them on board.
Working on it.
Right.
I think, gosh, this is just, we could carry on forever, couldn't we, Abbie? It's absolutely amazing. I knew this was going to be exciting, but it superseded certainly my expectation. But sadly, we've got to come to an end, haven't we now, Abbie? And you raise what you've raised, and it's the nice way to finish. They'll be the next goalpost to reach. Get the known celebrities in and give it the drive and focus. So I think we will probably come to a close, because it's been a long day for you guys, and other meetings beckon, don't they, Abbie?
Yeah, thank you so much, everybody. Thank you to all the speakers. Thank you to everyone for attending and for contributing to the discussions. It's been a fantastic afternoon, and such important material to take forward into the Better Birth programme. So I really appreciate everybody's contribution. Thank you so much, and thank you for your patience with the adjustments to the agenda and things. I think I just noticed Eugene's hand go up, maybe, or were you just clapping, Eugene?
Accidental, it was a clap.
No worries. I'll just hand over to Amanda just for a few final words, if that's okay.
Thanks, Abbie. I'm not going to keep everybody, because I think everybody starts to flag round about this time. I think what I'm always amazed at is the amount of discussion that's needed on topics such as these, and exploring themes and trends. So I think thank you for your contributions. It got off to a quiet start, but it got going, didn't it? So we just need to feed that back in, and we will come back out, because it feels, Abbie, like we need to think about setting up another sort of roundtable discussion on what this needs to look like across Bradford District Place. So I'm going to leave it there, and we're going to close, so everybody's got 5 minutes to have a comfort break and a drink. Thanks, Abbie.